and also the case studies presented by the HODs of Pudukkottai, Tanjavur or Tirunelveli? Tirunelveli and Dindigul. Please. So it is only a kind of their experiences. Please come. Any bite until otherwise proved should be regarded as a venomous snake bite. With that introduction, I call your name, sir?
Dr. Joseph.
Dr. Joseph.
A very good afternoon, one and all. On behalf of General Medicine Department, Pudukkottai Medical College, I am here to share our experience in the snake bite management. Slide, please. It's the statistics in Government Pudukkottai Medical College. It's the last 6 months statistics. So the male patients are totally 148 and female patients 93, of which only 2 deaths occurred. So both are neurotoxic snake bite, and the patients came late presentation, caused the death of the patients. So during rainy seasons, the number of cases were high compared to the January, February, March. The case loads are relatively less. So you have selected 2 cases for presentation that were saved by our medical team in Pudukkottai Medical College. Next slide, please. The first one, so 13-year-old boy referred from nearby GH on November 1st, 2024 with alleged history of snake bite over right leg at 9:20 a.m. for further management to our Pudukkottai Medical College Hospital. On arrival, patient arrived at 11 o'clock in the morning. So on arrival, the patient was conscious, oriented, and bite marks present. He had local swelling and tenderness, abdominal pain and vomiting present, but no history of bleeding manifestations, or no regional lymphadenopathy noted. So vitals were normal and on arrival. Next slide, please. So we checked the WBCT. It was more than 20 minutes on arrival. So 8 vials of ASV was started immediately, and the WBCT remained prolonged even after 6 hours of administration of ASV, and cellulitis is also progressing. So another 10 vials of ASV was administered to neutralize the venom and to arrest the progression of cellulitis. And the patient had prolonged PT and APTT, both are more than 2 minutes on admission. But the renal parameters were normal, urea is 25 and creatinine 0.9 on admission. Next slide, please. The next day, the patient developed acute renal dysfunction. Urea from 25 rise to 251, and creatinine from 0.9 to 4.3. So the acute rise in renal parameters within a day, and urine output significantly decreased, and his parents were informed about the need for renal replacement therapy. But initially they were very hesitant to accept hemodialysis, but later on, after repeated advice, so they gave the consent for hemodialysis. Next. So from 4th to 10th, the patient underwent 5 cycles of HD, and then renal parameters were started falling. In the meantime, patient developed severe anemia. So on admission, his hemoglobin was 13.5, and it is decreased to 4.8, and the next day, so 3.8. So severe decrease in hemoglobin, and patient developed thrombocytopenia also from 2.5 lakhs to 55,000, and the LDH levels are very high, and serum fibrinogen levels is reduced, and there's a mild increase in hepatic parameters, liver enzymes also noted. So the venom-induced consumption coagulopathy and thrombotic microangiopathy was suspected based on this clinical laboratory parameters. Next slide. So the RFT started improving from 10/4/2024. That means after the completion of 5 cycles of HD, so the renal parameters were started improving, and the hemoglobin also started to rise. So the supportive measures continued along with the broad spectrum antibiotics and packed cell transfusion. When you have severe anemia, so we gave one packed cell transfusion also. But peripheral smear showed microcytic hypochromic anemia with eosinophilia. Actually, no cystocytes seen. Next. The USG abdomen was done on the prior to hemodialysis. It showed grade 2 MRD with a minimal ascites, and patient showed signs of improvement from 11:11, and appetite and urine output, all the parameters including RFT and CBC improved, and the urine output became normal by 13th, and cellulitis almost subsided on 17th. So the patient was discharged on 18/11/2024 with the urea 41 and serum creatinine of 1.3. Almost all the parameters come to normal. Next slide, please. So the diagnosis was poisonous snake bite with hematotoxicity, acute kidney injury, thrombotic microangiopathy, query venom-induced consumption, coagulopathy was made. Next. So treatment, totally 18 vials of ASV administered. Initially we gave 8 vials followed by 10 vials, and 4 units of FFP also transfused because patient had prolonged PT and APDT on admission, which became normal after FFP infusion. So 5 cycles of HD performed, 1 unit of packed cell and broad spectrum antibiotic and supportive care given. Next slide, please. So with the continuous care and appropriate management, the 13-year-old boy was saved from multiple lethal complications. It's likely Russell Viper bites. This is investigation chart. So this abnormal values are in the red in color. So the hemoglobin from on admission it is 13.5. It's fallen to 4.8, 3.8. Then it started improving after some time. On discharge, the HB rose to 9.8. And this urea and creatinine also became normal after the initial rise. And this sodium potassium, so the potassium, so maximum 5.4, it also became normal after hemodialysis. And the PT APDT also became normal. Next slide, please. These are other investigations done. Next. This is the boy was saved by the timely management. So next slide. Next. We move on to the next case. This is a 40-year-old female patient, again referred from the nearby GH Arandangi GH with the alleged history of unknown bite over left foot on 19/3/2025. That means last month, around 3 a.m. at her home. It's a typical crate bite, early morning bite. So she had a difficulty in breathing and drooping of eyelids and difficulty in swallowing, and patient was taken to Arandangi GH. So in view of respiratory distress, patient was intubated there itself and referred to Pudukkode Medical College Hospital for further management. So on examination, patient arrived at 6:30 a.m. in the morning. So patient was drowsy and she was connected to ventilator, already intubated in Arandangi GH. She was connected to the ventilator. GCS was 10/15 and the vitals were relatively stable and SpO2 is 100 on endotracheal tube. She had ptosis and pupil size is normal, reacting to light on either side, and she had left foot swelling, tenderness and warmth plus, and other system examinations were normal. Next. So the diagnosis made was the unknown bite, so probable neurotoxic snake bite with the respiratory distress, and she had left foot cellulitis also. The investigations, so serial WBCD monitoring was done, so it showed less than 20 minutes, not even a single value was more than 20 minutes, and random sugar is normal, and the serial RFT, LFT and CBC values also normal, coagulation profile, electrolytes, ECG and chest X-ray all were normal on admission. Next slide, please. So the mechanical ventilation was continued, and the ASP 30 vials given totally. 10 vials was given in Arandangi GH. The remaining 20 vials completed in Pudukkode Medical College Hospital. And a neostigmine and atropine as per the protocol is given. So antibiotics and supporting aids also are given. Next. So the patient was slowly weaned off from the ventilator. On third day, she was extubated and cellulitis gradually subsided, and the patient was discharged on 24th, that is day 5 after complete recovery. Next slide, please. So the take-home message is in patients with unknown bites, either unknown bite or snake bite, with a neuroparalysis or respiratory distress. So the early administration is a key here. Early administration and timely intubation and mechanical ventilation is crucial for better outcome. So we should not wait for 6 hours for next dose of ASV in case of neuroparalysis. as soon as possible. So we have to repeat the ASV dosage with adequate, with the timely intubation, mechanical ventilation. So is crucial for better outcome. So thank you for the opportunity.
Is it a crate or a cobra?
So it looks like a crate, sir, but local patient had local cellulitis also, sir.
Was there any indigenous way of giving first aid in the house?
No, sir. So patient was taken to Arandang GH. So from there they intubated the patient and they referred to, so within 2 hours patient arrived to the GH. Sir.
So in the first case, why don't we have tried post-alkaline diuresis, sir? That's the one method that we can adopt because we can prevent the hemodialysis by using post-alkaline diuresis at very early stages. Because the first value was very normal, the second day the value gone up very high.
Yes, sir.
I don't know why it's gone up tenfold
Yes,
rise.
it's a sudden rise. Yes, sir.
That's the one. Is there any significant drop in the urine output during the 24 hours?
Yes,
If it
sir.
is so,
Yes, sir. Urine output is also decreasing.
so why don't we try the post-alkaline diuresis? That is in the protocol of National SnakeBite protocol treatment. The post-alkaline diuresis can prevent the hemodialysis.
Yes, sir.
That we can.
Yes,
That's the one thing that we can think it of here, sir. And definitely this is in VLCC only because it is an acute onset and more in favor of an thrombotic microangiopathy because you said there is a lot of cystocytes are present in the peripheral smear study. So the possibility for thrombotic microangiopathy, VLCC is much more than the DAC here. So we promptly
Actually, no bleeding manifestation, sir. Actually, no bleeding manifestation. But because of the laboratory parameters, we made the diagnosis. Sir.
Yes, sir. Yes, sir. But only the post-alkaline diuresis would have been tried. So we could have prevented all those other complications. We could have.
Sir, interesting case presentations and nice management, sir. I just wanted to know why the first case, 18 vials of ASV was given.
Yes, so initially the duty team gave 8 vials, madam. So followed by 10 vials. So the 10 vials should have been given on admission itself. Actually, no bleeding, sir. Sir, we took ultrasound abdomen, sir. It showed no bleeding. Maybe because of, could be because of gastritis or something, sir.
Sir, actually that case, the thrombotic microangiopathy, the nephrologist only decided. We asked for I was the professor there when now I so that case yes, actually. So we asked for the alkaline diuresis only. He said, I think he will not respond, and that was his answer. And abdominal pain, he said that whenever abdominal pain is presenting, he said the many cases go to renal failure. He doesn't know the reason. He said even acute tubular necrosis would have happened. But in that case, progressed very fast, worsened fast, and after 5 years he recovered fast. And
we had last week we had in our college patient similarly presented this. The second day itself the patient went for a drop in urine output, and then the platelet count was dropping to 50,000 and other things. So we started on post-alkaline diuresis vigorously. The patient responded very well. We've avoided the hemodialysis. So the first thing, that is very important is the early you start a post-alkaline diuresis, you can prevent the hemodialysis. That's very important. So you should expect to start a post-alkaline diuresis in a patient who is not passing urine. That's a key information that you must take, because that can prevent the costliest or more adventurous, more dangerous possible complications can be avoided with hemodialysis. You can stop it at any time. You can stop the post-alkaline diuresis at any time. The patient is not passing adequate urine, we can stop it and you can further proceed to the conventional hemodialysis. There is nothing wrong in it. It is not that we should not go for a hemodialysis. Attempt here, successful, it's good for the patient.
Yes, sir.
And then the second, this one, why the 30 vials again given? I think this is a standardized protocol we must proceed. Whatever it is, because this can lead into possibility of anti-SnakeBite serum sickness like illness. It can go for encephalitis, encephalomyelitis, and all other complications can develop if you give overdosing of anti-SnakeBite. The second dose is a neurotoxic SnakeBite. They have given 30 vials of ASB has been given.
So
The
actually
first
it's,
case is the vascular one. They are given less dose of ASB. Was
So actually, it's a very common practice in periphery colleges to give more ASV in case of neurotoxic snake, sir. But hereafter the
Yes, sir.
civil,
Yes. Yeah, that's only IU open. So we get to-
So that is the very purpose of this meeting, this workshop, to reach a uniformity in the management. So, well done, sir. Thank you.
Thank you,
So
sir.
we learn by our experience, our errors, and our discussions. Thank you.
Thank you, sir. Thank you very much, sir. Yes, sir. Yes, sir.